Hello, everyone. My name is Dr. Sanjay Aneja, and I'm from Yale University. Today, I'll be talking about applications of deep learning in diagnostic imaging analysis. I'd like to thank the National Academies for the opportunity to speak today and present our lab's work. So I'm a physician scientist. Clinically, I'm a radiation oncologist who primarily treats CNS and lung tumors. And my background is actually in applied mathematics. And so our lab primarily is interested in machine learning and the applications of machine learning in clinical oncology. We have a very multidisciplinary group of clinicians, data scientists, and computer scientists who help us in these efforts. A large portion of what we do is actually focused on diagnostic imaging, and I'm happy to share some of the work that we've done today with everyone. When we think about implementing a model, a machine learning model within clinical practice, we typically like to continue with the same pathway for model development. The first is asking a good clinical question. And by a good clinical question, I mean something that actually would provide tangible and actionable information for a clinician and actually translate to better outcomes for our patients. Then we'd find and collect appropriate data and make sure that our data source is robust. We'd compare model candidates, so specifically different types of machine learning models and the benchmark models, and making sure that the investment of using a machine learning algorithm is actually translated into a gain of performance. Second, we would externally validate on a blinded test set from another institution to account for any sort of biases that may be present in a single data set. And then lastly, as we implement these into practice, it's important that we surveil these and make sure that they're actually effective, and also do significant vulnerability studies. And so today I'll be talking about kind of the pathway in which we've sort of implemented this sort of model on specifically the task of identifying lymph nodes and lymph node classification. And these are two papers that we published within our group over the last few years that specifically used deep learning in the evaluation of lymph nodes using pretreatment diagnostic imaging. So in the interest of time, I'm not going to go through too much about the nuts and bolts of our algorithm, but sufficient to say it is a deep learning-based algorithm that uses convolutional neural networks, which are considered to be the gold standard in computer vision. Many tasks today that we use, many tasks today that we're not aware of actually use deep learning as the underpinnings, depositing checks, self-driving cars, tagging photos on Facebook, things of that nature. Oftentimes, people like to think that deep learning algorithms can learn different layers of abstraction. And so this is just a representation of that, where the pixel information is sort of built upon to develop a better understanding of classifying facial features. So the clinical problem, the good clinical question is the first piece. And so what we were interested in is trying to model lymph node classification, lymph nodes within cancer patients. The presence of lymph nodes within cancer, it really affects prognosis. And so there's some utility already in better classifying them. More importantly, identification of cancer within lymph nodes is difficult to complete non-invasively. And so oftentimes, if we really wanted to understand the extent of lymph node disease within patients, we actually require them to have a surgical procedure done. More importantly, the presence of extranodal extension within lymph nodes of cancer is often a justification to intensify adjuvant treatment. And oftentimes it makes the previous treatment of surgery almost redundant. And so there's a need for preoperative identification of patients with extranodal extension of tumor because it can potentially reduce the need for unnecessary surgical interventions and increase morbidity and mortality for our patients. So our hypothesis was that machine learning analysis of preoperative diagnostic images could effectively classify lymph nodes in head and neck cancer patients. First, we were interested in identifying if we could classify lymph nodes as positive or negative based on preoperative CT imaging alone. The next is that we were interested in identifying whether or not we could look at extranodal extension on a microscopic level within lymph nodes using the preoperative CT imaging and our deep learning algorithm. Here's a schematic from one of our publications, which kind of sort of explains how we evaluate our lymph nodes. The lymph nodes are segmented and evaluated individually. There's two inputs to our convolutional neural network. It is a three-dimensional convolutional neural network. And the output is a probability of nodal metastasis as well as a probability of extranodal extension. Initially, we trained our model on an institutional cohort, and we tested it on a blind institutional cohort as well. When we compared the model to a benchmark logistic regression of just clinical variables, we found that our model had a better discriminatory ability in both identifying nodal metastasis as well as extranodal extension. It's important to note that another candidate model, which is a random forest model of radiomic features, was also quite good at discriminating nodal metastasis versus extranodal extension. And so it's important to test multiple different models in order to identify which one's the best and looking at the trade-offs between those. The next piece of our study was actually externally validating it on a blinded cohort, first from patients within another health system at Mount Sinai in New York, and then secondly, using a national cohort of patients from the Cancer Genome Atlas from the Cancer Imaging Archive. In addition to this, so what we found when we externally validated on those two sources is that our model was continuing to have a good ability to classify extranodal extension among cancer patients. And more importantly, we also looked at whether or not the model was better than diagnostic radiologists trained to evaluate head and neck cancer patients. And what we found was that for both tasks and within both data sets, our model was as good or better than diagnostic radiologists at identifying extranodal extension. Now, I think that oftentimes people ask if this means that deep learning algorithms will replace clinical radiologists, but I think that the more important piece is here. What we found is that when the radiologists were given the information of the deep learning algorithm and had the opportunity to integrate that information, they had actually a performance gain. And so that suggests that these deep learning algorithms or these machine learning algorithms may not replace radiologists, but rather they could actually be used to help radiologists as decision tools and augment their clinical knowledge. In the last step, we are looking at surveillance and vulnerability studies. And so vulnerability studies is, to complete a vulnerability study, we are interested in looking at very difficult cases of extranodal extension. And so we've partnered with ECOG and have obtained the ECOG 3311 clinical trial data, which was recently presented at ASCO. The patients in this cohort are very unique because they have not clinically palpable lymph nodes. So their lymph nodes are all really small to begin with. And so these are what would be considered difficult lymph nodes to classify. The second piece is actually surveillance. And so what this is identifying what are the levers that are moving our deep learning model. And so what we see here is that we can identify the aspects of the model, aspects of the image that the deep learning model is looking at through this heat map on the right. What we can see is that the deep learning algorithm is actually identifying the areas of external extension within the lymph nodes. A few final thoughts. First, I think quantitative imaging methods appear to have clinical utility in clinical oncology. One, in non-invasive risk stratification of patients and avoiding potentially unnecessary biopsies and things of that nature. Secondly, to augment our own diagnosticians and clinicians in the form of decision aids. And then despite the enthusiasm for machine learning methods, I think there are necessary steps that are needed before we actually have clinical implementation. First, I think it's important that we do rigorous external validation at different sites. And also, I think it's important that we invest in interpretability and vulnerability studies. I'll open the floor for questions. I'd like to thank everyone for the opportunity to speak today, as well as all of those who support our lab's current efforts. Thanks.